Okay, it is noon, so I think we'll get started. Welcome to the second session of our Coding for Value-Based Payment Learning Forum. The goal of this 5-session series is to provide enhanced clinical documentation and coding practices, accurate and thorough documentation, and effective strategies and workflows to be successful in value-based care contracts. We have the speaker from Coding and Compliance Initiatives, Shelley Sulzberger, with us today. She also actually provided the last training and will be our trainer for the rest of this session. So welcome, Shelley.
Thank you. So welcome everyone. Good afternoon. So today we are going to talk about value-based healthcare related to hypertension, chronic kidney disease, and hypertensive heart disease. As we go along, if you have questions, please feel free to put them in the chat and then Terry or someone can let me know, or you can come off mute and ask. We'll also have time at the end, but if something does pop in your head, go ahead and feel free to put it in because we can stop partway through and answer those questions. We were going to talk also today about really how important it is to start looking at those combination codes for these conditions related to chronic kidney disease, heart disease that go with other conditions such as hypertension, or as we talked about in the last session, diabetes. A lot of times what we find with the providers is you pull from the problem list, and if our ICD-10 codes are not updated on the problem list, we continue to pull over individual diagnosis instead of those combination codes when the combination codes are more appropriate. We'll also talk about some key strategies for improving the documentation to make sure that you are coding and documenting to the highest level for reimbursement, not only for your value-based healthcare, but also for evaluation and management coding. So what are some of the things we want to consider when we're thinking about hypertension from a coding perspective? Hypertension only. So if that's what they have, we are going to be looking for that specific diagnosis if it's evaluated and managed during this encounter. We're also wanting to start thinking about some of those underlying conditions. So heart disease, kidney disease, do they have a tobacco abuse or nicotine dependence? So those are some of the things that we definitely want to start considering when we are coding for hypertension or when our patients are being seen for hypertension. So hopefully this visual will give you a good idea of kind of where we're going. So you can see here under the hypertension, it is I-10, hypertension only. When we start moving into some hypertensive heart disease, we're looking at the I-11 categories. So there's several different codes under that. And then hypertensive chronic kidney disease, we have two choices depending on the stage of the kidney disease. And then we have I-13, which is going to be a combination of our hypertensive heart and chronic kidney disease. So we are going to be looking in one of these categories whenever we are seeing a patient with hypertension. We're either going to code from a hypertension only, or if they have an underlying condition such as heart disease or chronic kidney disease or both, we're going to be looking in one of those other categories. So when we start thinking about hypertension, in ICD-10, there is not a difference for coding purposes for hypertension essential, benign hypertension, controlled hypertension, uncontrolled hypertension. All of those go back to I-10. So if your provider is documenting essential hypertension or uncontrolled hypertension, that is great. It gives us the descriptor, if we're reading it, as to what they are diagnosing that patient with related to their hypertension. But from a coding, we only have one code to pick from. Okay, so when we're thinking about our documentation, again, we're kind of looking at our history, our exam, and our medical decision making. So from the subjective portion, we are looking for the provider or the clinical staff to document information related to that hypertension. So we're looking for either some presence or absence of current symptoms. So are they having a headache, chest pain, leg swelling, palpitations, etc.? Um, or if there are not any current symptoms, patients here to follow up for hypertension, no chest pain, no headaches, no leg swelling, no palpitations. Are they taking their meds as prescribed? So things like that. There is not any specific requirement for your providers to document no chest pain, no palpitations. It is whatever they deem clinically relevant. But it has to show that we evaluated that hypertension if we're going to code it as a diagnosis. When we start to look at the objective, whoops, sorry, I don't know what happened there, guys. This is going to describe the physical exam findings that your provider did. So obviously we're going to have vital signs from your clinical team. Is there a cardiovascular exam? Are they looking at the lower extremities for edema, etc.? So again, what did the provider document based upon their findings from that exam? Then we move to the assessment. So as you all know, the assessment plan is key for not only your E&M coding, but value-based care coding. So we need to always make sure our diagnosis is documented to the highest level of specificity. So when we start to look at the assessment, patient was seen for hypertension, we have a subjective and an objective that correlates with the hypertension, and then our diagnosis of hypertension, and then a plan. So what is that patient supposed to do? So are they supposed to keep taking their losartan as directed? Are they supposed to follow with cardiology? Make sure that we're documenting that key information. Also, we want to go ahead at this time and document the status of the control. That helps with your E&M coding, not so much your diagnosis coding for value-based healthcare, because as I told you earlier, for hypertension, whether it's controlled or not, we only have one ICD-10 code for hypertension. We also want to know, though, if they have resistant hypertension. So that was a new code a few years ago that tells us to code first the type of hypertension, followed by the resistant hypertension. Currently, resistant hypertension is not on the value-based scoring. So there is not a RAF code. There's no HCC code for resistant hypertension, but it is important to describe the type of patients that you're taking care of. And as I said earlier with the plan, this is where you're going to document specific and a concise treatment plan for that hypertension. This is also where, if there's anything else that you're thinking about, providers from another diagnosis or medication they're on that you have to think before you decide what you're going to do with that hypertension, this is where we need you to kind of connect the dots for us. So really looking at the plan, we want to make sure, do you want them to continue a medication? If so, what medication? Are you starting a new medication? Are you increasing a dosage? Are you decreasing a dosage? Are you making consults or referrals? All of this is really important. More and more payers are starting to look to see if our assessment and plan is really patient specific, or is it some template that we've listed on every single patient? Also, when you're documenting, this is really important for the providers. Think about when you list your final diagnosis. I'm starting to see when I do chart reviews where you guys as providers are saying history of hypertension, history of chronic kidney disease. In a coding world, History of means that that patient had that diagnosis. They are no longer taking any medications. That diagnosis is completely gone. So, for example, I had a pneumonia, I was treated, the pneumonia is gone, I have a history of. If the patient has hypertension, but it's well controlled because they're on a medication, they still have hypertension. So, why is this important? This is important because if you as a provider say hypertension or history of hypertension with chronic kidney disease or history of stage 3 chronic kidney disease, if that diagnosis is on the value-based list and it's coded with a history of, you're probably getting 0 credit for that. So if they currently have that diagnosis, we're going to list it as a current diagnosis, not a history of. So here's a progress note example. Patient presents today to follow up on their hypertension. They take their medications as prescribed. They're not having any chest pain or headaches. So we have the subjective portion. Objective, we have the blood pressure. Some providers might have a cardiovascular, some might have lower extremity edema. It's whatever you deem clinically relevant. Diagnosis, so our assessment plan. Hypertension, not at goal. The plan is to increase the losartan, but the patient wants to try diet and follow up in 1 month. So again, we have our diagnosis to the highest level of specificity that we know at this current visit. So our claim form will be submitted with ICD-10 code I-10. I-10 is not an HCC code. So this does not help your RAF score, so that risk adjusted factor for value-based coding. So coding hypertension, I-10. Diagnosed with hypertension, 1 disease, 1 code. Okay, so when I have hypertension, I'm going to have only 1 diagnosis unless there's a combo. And on this case, there's only 1 diagnosis, 1 disease, 1 code. Okay, so hypertensive heart disease with heart failure, those ICD-10 codes are HCC codes, meaning that there is a risk adjusted factor so that you get credit for value-based healthcare. There's an instructional note with the I-11 codes, the hypertensive heart disease with heart failure, that you must use an additional code to identify the type of heart failure that patient has. There's also an ICD-10 code for hypertensive heart disease without heart failure. And there is a specific set of codes that can be coded with this I-11.9. I-11.9 is not an HCC code. There's no risk adjusted factor with that code. So let's look at some of the codes that are part of the hypertensive heart disease. So we have to use an additional code, as I said earlier, to identify the type of heart disease. So with that first code, let's go back and look here, our I-11 with heart failure, we must have a code from the I-50 section. We have to have that. If we report I-11.0, we must report a corresponding code from I-50. If we report I-11.9, we must have one of these codes here: myocarditis, myocardial degeneration, cardiomegaly, etc. You must have one of these I-51 codes. So for my coders on the call, remember, hypertensive means the condition is due to the hypertension. So if the relationship between the heart failure and hypertension is not identified by your provider, so the provider does not specify in their note hypertensive heart failure, your official coding guidelines indicate there is a causal relationship between those diagnoses unless the provider tells you they are not related. So if you see that your provider is reporting I-10 and I-50.X, as long as the documentation does not specify that these are not related, then you can code that I-11.0 code in addition to their I-50. So you would replace your I-10. We also really want our providers, if you know the type of heart failure, please specify that instead of heart failure unspecified, I-50.9. Try to document to the highest level of specificity to describe the type of patients that you are taking care of. So let's look at an example. So we have a 74-year-old female who presents to follow up on the hypertension, no complaints, takes medications as prescribed, no lower extremity edema, no shortness of breath, not even during exertion. Vital signs, 130/82. Our final diagnosis, hypertensive heart failure at goal, continue XYZ medications. So with our documentation, we can see that the provider did document to the highest level of specificity as far as we know. We would come over here and we say, yes, our hypertensive heart failure is documented to the highest level. We don't know the highest level of the heart failure. That's okay. If we don't know at the time of coding, providers can report unspecified. Both of these are HCC codes, so you would get credit for value-based healthcare under your RAF score. So even though it is an unspecified, it still does help get you part of that RAF score on your value-based healthcare. The reason we want you to report to the highest level of specificity is because it describes the complexity of your patients. Also, the other reason it's really important is because sometimes those higher level of specificity, so if this said systolic heart failure or diastolic heart failure, those might have a higher risk score on the value-based care. So they're all mapped over to a specific code, which quantifies with some other information like demographics, etc. It gives us a score for that risk-adjusted factor. Not always, but sometimes if it's more specific, it gives us a higher risk score or higher RAF score for that specific diagnosis. So I have hypertensive heart disease, that I-11 category. So this means my patient has hypertension and hypertensive heart disease. Two diseases, right? Hypertension and heart disease. Providers, that means that you have to bring in two codes in your assessment plan. The hypertensive heart disease followed by the type of heart disease or heart failure. So again, two diseases, two diagnoses, two codes. Also, when you are documenting your diagnosis, this is above and beyond value-based healthcare. Specify if your diagnosis is at goal or not. So hypertensive heart disease at goal, not at goal. The American Medical Association has been really clear that it is not up to a coder or an auditor to determine if your patient is at goal or not. Why is that important? It is important because it might impact your E&M coding. Not value-based healthcare in this scenario with the hypertension, because we only have one hypertensive type of code. So we don't have anything to specify if it's at goal or not at goal, but it does help in your E&M coding. Okay, so then we move to hypertensive chronic kidney disease. So we have a 42-year-old male who presents to follow up on his hypertension and chronic kidney disease. He's not taking his medications today yet. However, he's been taking them every day as directed. He's eating well, no fatigue, no weakness, no changes in urine output. Blood pressure 140/86. Hypertensive chronic kidney disease, stage 3B. What would make this note a little bit better for us is to specify if that hypertension is at goal or not. But from a value-based perspective, we have hypertensive chronic kidney disease. So we have the combination code and we have the stage of the kidney disease. So our claim form will be submitted with two diagnoses: hypertensive chronic kidney disease and the stage of the kidney disease. So I-12.9 is not an HCC code. However, it is the most specific diagnosis to describe the complexity of your patient. However, in 18.32, my chronic kidney disease stage 3B is an HCC code. So providers, what does that mean for you? That means that you've documented your diagnosis to the highest level of specificity, and you will get credit for this patient for value-based healthcare based upon my chronic kidney disease stage 3B. So I have chronic hypertensive chronic kidney disease. I'm going to be looking in my I-12 category. My patient has hypertension and chronic kidney disease. Two diseases, two diagnoses, two ICD-10 codes. My hypertensive chronic kidney disease is always going to be with an I-12, followed by my secondary code of the chronic kidney disease. Depending on the stage, it's N18 something. Okay, so then we move along to hypertensive heart and chronic kidney disease. Again, we always want to specify if our chronic conditions are at goal or not. Always. That is so important for not only the E&M code, but the reader to know the type of patients you're caring for. And as I said earlier, there's a relationship between different diagnoses. So between chronic kidney disease, heart failure, and hypertension, our official coding guidelines tell us, even if the provider doesn't specify hypertensive heart failure and chronic kidney disease, as coders, we can assume that causal relationship, and we are allowed to do a more specific code unless our documentation indicates that those are unrelated. So your provider says, hey, this patient has hypertension, heart failure, and chronic kidney disease, but the chronic kidney disease and heart failure are completely unrelated to the hypertension, then you could not do a combination code. So we always want to make sure that we're coding to the highest level of specificity. So our 70-year-old patient presents with hypertension, congestive heart failure, and worsening chronic kidney disease. He doesn't want to go on dialysis, no fatigue, leg swelling, etc. Vital signs. Our final diagnosis. So we can look here in our assessment plan, and we can see that the provider did not document the hypertensive chronic kidney disease and heart disease to the highest level. When they pull in HTN, that's going to pull in an I-10 diagnosis for them. So again, if a coder stops this, which we know that doesn't happen in every clinic, it's not cost effective. We don't have time to look at every note. But if we did happen to pull this one, we could update this to the highest level. The chronic kidney disease stage 4 is documented to the highest level, and chronic systolic heart failure, again, to the highest level. So we know that at least we have 2 out of the 3, but our coder could change that if needed. And then we have a plan. After discussion about dialysis, the patient feels they're doing well with their current medications and doesn't want to start that. So again, we're starting to say, okay, do we have enough to code to the highest level? So based upon the documentation, we would code I13.0, hypertensive heart and chronic kidney disease with heart failure, stage 1 through 4 of my chronic kidney disease, or unspecified. So I have stage 4, so I've met that criteria. And I have heart failure. Again, I've met this criteria to code I13. All three of these are HCC codes. Now remember, with value-based healthcare, if all of these codes map to the same HCC code, you get credit one time. If they map to different HCC codes, then you get credit for each of those. So obviously it's hard for anyone to keep track of which codes each ICD-10 correlates with. So for providers, always document to the highest level of specificity, always. Outside of value-based healthcare, it describes the complexity of the patients that you are treating. So we have hypertension, heart disease, and chronic kidney disease, I13. So we have, again, 3 diseases, 3 diagnoses, 3 codes. Okay, hypertension, heart disease, chronic kidney disease. 3, I need 3 codes. So I'm going to have my I13 code, depending on where it falls, hypertensive heart and chronic kidney disease. I'm going to have my heart failure code, I50 something, and I'm going to have my chronic kidney disease, N18 something, depending on the stage. 3 diagnoses, 3 diseases, 3 separate codes. As I said earlier, there is a relationship between hypertension and heart involvement, and between hypertension and kidney involvement. So from a coding perspective, as I said earlier, coders can code the combination codes whenever they're looking in the ICD-10 book, and they're linked either with or due to or associated with, secondary to. The key is for the coding team is that you have to make sure that the provider doesn't say these are unrelated. Most coders are not pulling every note. We don't have time to look at everything. It's not cost effective. So this is where we're doing training for the providers to get them to start documenting to the highest level. Let's quit pulling from the problem list, because that's what's there. Let's update the problem list so that we can code correctly. So when we start thinking about tobacco use or exposure, there are instructional notes throughout our entire ICD-10 book. For example, with hypertension, the hypertension codes tell a reader, please use an additional code to identify if the patient has any kind of nicotine dependence, tobacco abuse, if they're a former tobacco user, if they're exposed to tobacco or nicotine. So again, this tells us that if we see that, we should be coding for that nicotine dependence, tobacco use, history of, etc. For my coders on the call, one thing I'm starting to see with my chart reviews is that sometimes what will happen is the provider will tell us throughout the note, maybe that the patient's a smoker, but they never put that in their final diagnosis. And I'm seeing that coders are starting to use F17.210 nicotine dependent cigarettes, for example, because the social history says the patient smokes every day or multiple packs a day. We cannot diagnose patients with a dependence unless the provider tells us. You could use the tobacco use code, the Z72, but we need our providers to tell us if they have a nicotine dependence, and if so, is it cigarettes, is it chewing tobacco, etc. So all my F17 codes identify some kind of nicotine dependence. So as I said earlier, like F17210 identifies a nicotine dependence related to cigarettes. F17.220 identifies a nicotine dependence for chewing tobacco. F17.290 identifies a nicotine dependence for other tobacco products. If the documentation indicates that the patient has occupational exposure to environmental tobacco smoke, we have a Z code we would report. If they have a contact with or a suspected exposure to tobacco smoke, then we would report the Z77.22. Now, with this, there is an instructional note that says, hey, wait a minute, guys, you can't report this code, the contact, if they currently are nicotine dependent or tobacco abuse or use. And then we also have the personal history. So these are not HCC codes. Why am I including it in this training? Because again, we are trying to educate you guys as providers to document to the highest level of specificity. When a patient has hypertension, and especially when it's not at goal, the tobacco use, dependence, exposure helps to tell a story about the complexity of that patient. So these are not HCC codes, but they are important in describing the complexity. So as I said earlier, with chronic kidney disease, we always have to code the type of kidney disease. They all start with N18. With that diagnosis of chronic kidney disease, there is an instructional note to always code first any associated diagnosis. So diabetes, hypertension, etc. There's also an instructional note to code a kidney transplant status. Now, kidney transplant status is not currently an HCC code. Many of the transplant status codes, they're Z codes, are HCC codes. So if your patient has a heart transplant, it's going to be really important for you guys as providers to get that on your claim form at least one time during the year to get credit for that HCC code. Even though kidney transplant status is not an HCC code, I would tell you it's still really important to get that on your claim at least one time a year. Why? Number one, it describes the complexity of your patient. Number two, there is a chance that that code will be put back on the HCC code list. And so if you're already in the habit of that, then you're going to be in the habit and get credit for that if it goes on the next version when they update the HCC codes. End-stage renal disease does have an instructional note to use a diagnosis code for dialysis. That code Z99.2 is not an HCC code, but the same methodology. Number one, it tells us we need that code with our end-stage renal disease if they're on dialysis. And number two, describes the complexity of your patient. And last but not least, if that ever is added to the HCC codes, you are in the habit of reporting that. One other important fact for all the providers on the call, there is an instructional note for chronic kidney disease that says no matter what stage of chronic kidney disease, if the patient is on dialysis, we always code with N18.6, which links over to end-stage renal disease. So no matter what the stage is, if they're on dialysis, we will go ahead and report N18.6. It is important for all of you to know that when we are reporting our ICD-10 codes for chronic kidney disease, if you select this last one, N18.9, chronic kidney disease unspecified, There is not a risk score. This does not have an HCC score at all. The codes that have an HCC are stage 3, 3A, 3B, 4, 5, and end stage renal disease. Now, obviously, if you don't know the stage and it's not easy for you to get, then you code what you know. But don't just pull that over because it's on the problem list. All right, so for heart failure, some things we have to consider from a documentation and coding perspective. We need to know the type of heart failure. Is it systolic? Is it diastolic? Is it combination? We need to know, is there an underlying cause for the patient's heart failure? Do you have the most recent ejection fracture? And if so, document that. Does the patient have a current condition that reflects like an acute exacerbation, or is the condition stable? Also, is the patient on oxygen? Are they dependent on oxygen? If so, make sure that we document that as well. A couple of reminders. If your heart failure is caused by another disease, for example, coronary artery disease, make sure that you include that code and kind of make sure there's a link between them. Also, if you are documenting and you're really good about specifying acute versus chronic versus acute on chronic, make sure that the documentation reflects that throughout the note. So again, the subjective for heart failure documentation, again, this is your patient's story. This story can be documented and taken by the clinical team or your providers. This is where we're going to look for the presence or absence of any of those current reported symptoms of heart failure by your patient. So, are they having shortness of breath? Are they having fatigue, leg swelling, those kind of things? Are they taking their medication? In our objective portion, this is, again, the physical exam findings by your provider. So maybe they'll have a cardiovascular exam. Maybe they'll look at their jugular venous. Do they have any distension, edema, any weight gain from their weight that was taken today? Do they have any wheezing or crackles in the lungs? Anything like that we're looking for from the provider, whatever they deem is clinically relevant to that current visit for that current patient. The assessment, this is where we're going to document and find our diagnosis or our signs and symptoms. So as a reader, I'm looking for that provider to tell me the highest level of specificity on the heart failure. So hypertensive heart failure, is it acute, chronic, acute on chronic? Is it diastolic, systolic, etc.? I need to know the highest level of specificity on the heart failure. Again, as I said, I want to know the cause if we do know that. So is it hypertensive heart failure? And then what's the current status of that? Is it stable? Is it worsening? Is it improved? Is it in remission? Is it compensated? Is it decompensated, etc.? I need to know all of that information. As we talked about earlier with all diagnosis, do not document history of if you are describing a patient that currently has heart failure. When we see history of, that implies that a condition has occurred and no longer exists. So I might have heart failure that's well controlled by my medication. I don't have a history of, I still have a current heart failure, well controlled, or echo, whatever words you like. So then in my plan, again, I'm looking for a clear, concise plan for the heart failure. I'm looking for the link to any medication. So continue XYZ medication, follow up with cardiology. If there's lab work or diagnostic testing, so are you getting, a CMP? Are you doing imaging, stress tests? Anything that is in the plan, patient's going to follow up with someone else, follow up with you. When are they coming back and why? Follow up in 3 months for hypertensive heart disease, whatever they're following up for. So this slide, hopefully for providers and coding and quality teams, this gives you a really good picture of how important diagnosis coding is. So when your patient has, let's just go with hypertensive chronic kidney disease, but providers report I-10 and N18.9 because we just pulled from the problem list, right? On this visit, you are going to get 0 credit in value-based care. 0. If your providers are like, great, I can get that more specific hypertensive code, so I'm going to code I-12.9, or we're having coders pull all of the hypertension that has a chronic kidney disease diagnosis, and they're like, great, I can update this I-10 to I-12.9. So now my claim reports I-12.9, hypertensive chronic kidney disease, and my claim supports N18.9, chronic kidney disease unspecified. 0 credit for value-based care. These 3 codes do not map to an HCC code in version 28. That means for you guys, we don't have any value-based score for this patient at all. Now, let's say our providers pulled over I-10 off of their problem list, but they also documented the chronic kidney disease to the highest level of specificity. So I have I-10 and I have N18.32 to identify stage B. While this is not the most specific code, I still am getting credit for my HCC. There is a risk score because N1832 maps to an HCC code. Let's say our providers did a great job, gave me the hypertensive chronic kidney disease and N18.32 for that stage 3B. I am getting credit for my HCC score. As I told you earlier, anything from chronic kidney disease stage 3 through end-stage renal disease, they all map to an HCC code. Stage 1, 2, and unspecified do not map to an HCC code, meaning no credit for that. All right, so how do we get there? How do we help our providers? How do our providers get credit for the complexity, the value-based score that they deserve for that specific patient? So with our MAs and providers, we need to be pre-visit planning. If you are not pre-visit planning, you might be missing the boat. So we should have a set checklist for our clinical team and our providers for pre-visit planning. What do I want my medical assistants to do? Every single patient that is being seen tomorrow or this week, whenever I'm doing my pre-visit planning for hypertension, I want to go over to the problem list and look to see, number 1, do they have any chronic kidney disease? If I see that, I want to know Is the diagnosis listed on the problem list identify a stage, or does it say unspecified? I also want to know, is there more than one chronic kidney disease on my problem list? Why do I want to know that? Obviously, the stages change. Maybe I was unspecified, but now there's also a 2 and a 3B. Which one is it today? So I need to talk to my provider so that my provider during our huddle can update that problem list. I want to know if there is a chronic kidney disease, are they on dialysis? Why do I want to know that? Number one, I want to make sure that my chronic kidney disease correlates. So I should have an end-stage renal disease listed for my coding. And I also should make sure that the dialysis code, that Z code, is listed on my problem list for my provider to pull over. I also want to look under the surgical status to see if my patient has had a kidney transplant. So I want to talk about that during the visit with my provider, that huddle, so that when we visit in the morning at our huddle before we see all our patients, I can identify which patients had a kidney transplant status, if any, so that our providers can include that diagnosis during that visit. Heart failure. Again, I'm going to look at my problem list. So I've identified anything about chronic kidney disease if they have it. If not, I skip that and go straight to heart failure. If they have heart failure, how many diagnoses are listed? Or is it say heart failure unspecified? This is really important to train our medical assistants what to look for. Because then when we visit during our huddle in the morning, we can talk about that so that the providers can make sure that they are getting the highest level of specificity. Or if they don't have that information, they can start directing, like, hey, can you call cardiology? Can you call nephrology? Let's get the latest lab or the latest progress note, something to help that provider get to the highest level of specificity and update the problem list accordingly. I also want to know during my pre-visit planning, is there any tobacco use history of or exposure? I want to make sure to talk to my provider during that morning visit as well. Of course, this is going to be verified when I room the patient because something may have changed, but I at least want to start notifying my provider. I can update my provider if something has changed. For example, if it says that I am a current cigarette smoker, we talk about it with my provider in the morning. I room the patient and the patient goes, oh my gosh, I quit smoking 3 months ago. I haven't had a cigarette since. We can update our provider during that time because we're going to update the social history and let the provider know that as well. So that MA is going to look at that problem list. So a lot of you are using like Azara or other things for your pre-visit planning, but you've got to add in some key things to help above and beyond with that value-based healthcare. Every patient follow-up for hypertension on my schedule, I need to go straight to my problem list. Chronic kidney disease, heart failure, tobacco. Those are my 3 things I'm looking for. If any of those are yeses, I need to dig in a little bit more. Chronic kidney disease, yes, I need to dig in. What stage? Are they on dialysis? Is there a transplant status? If there's heart failure, I need to look, dig in. Do I have the highest level of specificity? Are they on oxygen? If I see there's any kind of nicotine, I need to know, is it updated to the highest level? Is there a use, abuse, dependence? Does it say unspecified dependence, which many EMRs have it listed as F17200, unspecified. So if that's what I see, I need to educate my provider. So we've done our pre-visit planning. The morning we huddle. Dr. Jones, our 9 o'clock. Lucy Lynn is coming in. She's got hypertension. There's no chronic kidney disease, no heart failure. It does say that she used to smoke. Our 12 o'clock's coming in for hypertension. It does show chronic kidney disease unspecified. My provider should be able to say, Unspecified. Shelly told me on that call that gives me 0 credit for my value-based score. Can you call nephrology and get the latest note because we don't have one for over a year? So these are things we can start doing internally. What else can we do? We can use our coding team to run some reports. How many N18.9 are listed? And they're coming in within the next 2 months. Our coding team can develop that report, send a list to the provider or clinical staff. Here's all your patients coming in the next few months that have N18.9. So we can start reaching out to nephrology or trying to find the latest GFR, CMP to get the highest level of specificity. So we can have multiple teams working different ways to help improve our value-based score. N18.9 is low-hanging fruit. That is where you want to focus. That is going to drive my value-based score. I told you earlier, heart failure unspecified, it has an HCC score. I want you to get to the highest level of specificity, but you get 0 credit on chronic kidney disease unspecified. So that is low-hanging fruit we can immediately go after. So have our MAs and providers pre-visit planning, have our coders running some reports and creating a list of who's coming in the next month or two so that you can start getting what you need ahead of time to update that problem list. All right, so remember, we're looking for the underlying cause, diabetes or hypertension. We're looking for, is that chronic kidney disease related or unrelated to the diabetes or hypertension? If it does not specify unrelated, there's always a cause and effect that is assumed from a coding perspective. So we would indicate that patient has diabetes with chronic kidney disease, hypertensive chronic kidney disease. I need to know the stage of the chronic kidney disease. Remember, 3 and above give you an HCC score for value-based care. Unspecified does not give you a score. Again, coders cannot code from diagnostic reports alone. So even if you gave your coders a cheat sheet and said, when you see this GFR, it means stage X, they can't do that. Providers, you have to specify the stage. I need to know, is there presence of an AV fistula or shunt for dialysis? I need to know if there's any complications due to that access device for their renal dialysis. Is there an implant or graft? If they are dependent on dialysis, is it hemodialysis or peritoneal dialysis? I also need to know if there's any associated conditions or other diagnosis. As I said earlier, diabetes with chronic kidney disease followed by the stage of the kidney disease. Hypertensive chronic kidney disease, again, 2 codes. I need to know the stage of the kidney disease. If the patient does have a secondary like hyperparathyroidism due to chronic kidney disease, we will need both codes, again, with the stage of the kidney disease. And then we need to know if they have a transplant status. Again, as I said, that doesn't have an HCC score on version 28, but many of the transplant status codes do map to an HCC code. So it is likely that this could end up in a different version on the HCC codes. So the more you get in the habit of documenting it at least once a year now, if it goes on the next version and maps to an HCC code, you'll already be in the habit of that. And secondly, it does describe the complexity of your patients on a claim form to a payer when they're looking at your levels of service or your frequency that you're seeing patients. Okay, so kind of just to summarize, for providers on the call, If I have hypertension, we need to know and code and document if they also have chronic kidney disease or any kind of heart disease. And then we also need the chronic kidney disease and the hypertensive heart disease to the highest level of specificity. Don't just pull over from your problem list. Utilize the workflow options of your medical assistant and your coding team to help with that low hanging fruit to start improving your diagnosis codes as well as your risk score of the patients that you're taking care of for that value-based score. Okay, what questions or comments or thoughts do you have? We've got about 5 minutes, so this is your time to ask questions. If you have a good process you want to share with others, this is the time to do that as well. Remember, there's not a dumb question. If you're thinking of something in your head, I can guarantee you that other people on the webinar are also wanting to know the answer to that question. If you don't want to ask out loud, you can just put it in the chat, and then Terry can let me know what's in the chat and read that to me as well. Any questions? If your clinical team is not pre-visit planning today, looking above and beyond just those gaps from a Zara or something similar, I would highly recommend talking to your director of nursing or whoever's operationally over your clinical team to start talking to them about how to pre-visit plan, things they should look for. We've talked about last webinar on obesity and diabetes, this one on hypertension, heart disease, and chronic kidney disease. Remember, you cannot eat an elephant in one bite, so pick 2 or 3 things to work on. Get really proficient at getting that diagnosis to the highest level, and then you can work on 2 or 3 more to get it to the highest level. But some of that low-hanging fruit, like the chronic kidney disease, are things that you can start with now. And we talked about obesity last time, how important it is to either get the class on there or the highest level. Don't just go E66.9, because if they are morbidly obese, that does risk score. So we want to make sure that we're getting those diagnoses to the highest level so that you get credit in your value-based scores for those diagnoses.
All right, Shelley, I don't think we're going to get any questions.
I know everybody's so quiet.
Yeah, well, I think that's a sign that you've provided the information very, very well. So I appreciate that. Thank you everyone for joining, and I put the link to the evaluation in the chat, so take some time to do that either before or after you leave. So with that, we'll call it a day, and have a great afternoon.
And Terry, I will send over the slides and the tip sheets for today's webinar so that you'll have those to post.
All right, thank you so much.
You're welcome. Thanks, guys. Have a great day.
Take care, everyone.